So good morning everybody. I am Dr. Lohith, SR Pediatric Surgery. My colleague Dr. Renita has briefed you about what happened with the patient in the emergency. I will be discussing like what we did in the ward. After shifting to the ward by 8:30, the general condition of child was sick and child was dehydrated, and blood gas was showing increased lactate. So we stabilized the child by giving boluses, and the HP of the child was also 8.5. So we gave blood also, and we resuscitated the child till the urine output improved, and color also became light in color from that. So we took the child to OT by 3 p.m. on that same day. So, this is the pre-operative picture of the child showing gross distension of the abdomen. And the surgery done was laparotomy. It was done via right upper quadrant transverse incision approach. And intraoperatively, we noticed a Meckel's band obstruction, which was causing the compression of the bowel. And the bowel which was compressed was about 20 centimeter proximal to the IC junction. It was about a length of 20 centimeter of ileal segment was gangrenous, and so this is gangrenous segment, and this is a Meckel's band which was causing compression, and this is a proximal bowel loops which was dilated. So we excised the band, and along with the Meckel's diverticulum and the gangrenous segment was resected, and end-to-end ileostomy was done. So post-operatively, the child was shifted to our ICU, intubated on inotropic support, and antibiotics were hiked up as there were ascitic contamination. No, there were no contamination, but the bowel was gangrenous and child was looking sick. So antibiotics were put on meropenem and metrogyl. There was gradual improvement in the child from post-op day 1, 2, 3. We gradually tapered the inotropes and extubated the child from the ventilator. Between post-op day 4 to 7, the NG output, it was initially bilious, gradually decreased, and it later became lighter and became gastric. And NG was clamped, and child's abdominal distension also in this time reduced, and child started passing stools. And in between 4 to 11, the child NG was removed, and initially child was allowed sips, and progressively increased to liquids, and later solid food was allowed. And by post-op day 12, the child's general condition was improved, and child was discharged in a stable condition. So this is the picture taken of the child about the time of the discharge. Child was discharged in a very stable condition. So these are the pictures of not this case, but other cases of the Meckel's diverticulum being which was performed in our department. So this is also a Meckel's diverticulum which was causing obstruction of the bowel. It's also the Meckel's diverticulum is also showing inflammatory features. And this was the case in the, where the Meckel's diverticulum was causing the GI bleed. So in the Meckel's diverticulum there was ectopic gastric mucosa, and the Meckel's diverticulum was excised, and end-to-end anastomosis was performed in this case. So I will be discussing Meckel's diverticulum as it is a common cause of obstruction and lower GI bleed in pediatric age group. So outline of my discussion is like this. And during coming to embryology, during the embryonic development of fetus, the yolk sac initially nourishes the child via vital and circulation. The intracoelomic part of the yolk sac forms the gut, and extracoelomic part is gradually regresses and replaced by placenta as a primary source of nourishment. And with the growth of the fetal intestine, yolk sac regresses and forms omphallomesenteric duct or vitelline duct, which obliterates by the 5th and 7th week of fetal life. So this is briefly about embryology, and coming to the anomalies of failure of involution of omphallomesenteric duct. So about Meckel's diverticulum, which 25% attached to the abdominal wall, or in 75% cases it is not attached to the abdominal wall. There can be a vitelline cyst with mucosal lining. These may be just beneath the peritoneal lining of the abdominal wall. And there may be persistent vitalointestinal or omphalomycentric duct with mucosal lining, cause omphaloileal fistula, and there can be a fibrous vitelline attachment without a diverticulum. This can be also happen. So coming to epidemiology, it's the most common congenital anomaly of GIT and found in 1.2 to 3% of population, and it is nearly equal in asymptomatic patients male to female ratio, but in symptomatic patients it is more common in males. So rule of 2 is often cited regards to diverticulum. Two types of heterotopic mucosa, that is pancreatic and gastric mucosa, is present, and it is usually located about 2 feet from the IC wall and to about 2 inches long, 2 centimeter in diameter, usually discovered before 2 years of age, and more common in males, 2 times more common in males, and found in 2% of population. So coming to the pathology, it is a true diverticulum. It involves all layers of the bowel wall, and the incidence of heterotopic mucosa, which is I have already discussed, that pancreatic or gastric mucosa is seen in around 15 to 50%, and gastric mucosa is more common. So other types of heterotopic mucosa also can be seen, but are rare, such as colonic, endometrial, and pancreatic. And this bleeding and inflammatory complications of this Meckel's diverticulum is usually attributed to this ectopic mucosa. So gastric acid production from this ectopic mucosa causes ulceration and bleeding from the normal ileal mucosa. So coming to the diagnosis, so technetium-99 pertechnate scan, which is specifically concentrates in the gastric mucosa, and it is excreted through the bladder. So when we perform this Meckel scan, the patient is usually catheterized. In the scan, wherever the uptake of the technetium-99 is there, that part appears as darker in the scan. So we can see here one ectopic site, which is suggesting us of Meckel's diverticulum. And usually in CT generally Meckel's diverticulum is not usually seen, but in this case sometimes Meckel's diverticulum causes inflammation and can be seen in the picture. This is Meckel's diverticulum showing inflammatory features, and other signs like intussusception or like a cystic mass, it can be appreciated. So coming to clinical presentation, it's one of the it is the common cause of lower GI bleed. About 50% of the patients having lower GI bleed, Meckel's diverticulum may be the cause. And differential diagnosis of the lower GI bleed others include intestinal polyp, inflammatory bowel disease, duplication cyst, hemangiomas, and AV malformation. So usually the child presents with anemia of usually less than 8 hemoglobin, and the bleeding is painless, which is most common. So unexplained isolated anemia may be the sole presentation in this small fraction of children. So coming to the next case, so there is obstruction, which is like relevant to our case, index case. So there are like many ways in which Meckel's diverticulum can present as obstruction. These are like intussusception, which is the more common way of presenting child, where the Meckel's diverticulum acts as a pathological lead point, and this type of intussusception usually doesn't reduce completely with a pneumatic reduction, and a loop of intestine kinked around the fibrous vitelline remnant, volvulus around the vitalointestinal duct or around the Meckel's diverticulum, and self-knotting of the Meckel's diverticulum may also lead to obstruction. Internal herniation of the ileum under the mesodiverticular band, mesodiverticular band can also, or vessel can also lead to the obstruction, and Litter's hernia. Litter's hernia is a form of indirect inguinal hernia where the content of the hernia is a Meckel's diverticulum. So Meckel's diverticulum becomes the content and may lead to the obstruction of the bowel. So intussusception, as I have discussed, is slightly more common among the presentation. Presentation is like normal obstruction features with dehydration, lethargy, and lower abdominal mass, and red currant jelly, blood in stools can be seen. And ultrasound usually confirms target sign we can see, but it rarely identifies the Meckel's diverticulum as pathology. So as I have already discussed, complete reduction is usually unsuccessful when a pathologic lead point like Meckel's diverticulum is present. Other findings like volvulus can result by the twisting of the bowel around the fibrous band or vascular white line intestinal ligament. So a long diverticulum can also even knot on itself, as I have told. So preoperative preparation, as we have already discussed, we have to hydrate the child, keep the child NPO, and put the nasogastric tube, and we have to do a VBG immediately and correct the electrolyte abnormalities and catheterize also the child. And antibiotics should be initiated in any case of obstruction, because as our Dr. Renita has already discussed, transgas bowel seepage of the bacteria into circulation can happen and lead to sepsis. So resection of the diverticulum and end-to-end anastomosis is usually the preferred mode of treatment. In case the bowel is unhealthy, we may perform stoma occasionally. So mesodiverticular white line remnants can also cause internal hernias when small bowel is untrapped and may get strangulated. Adhesions can also result in obstruction, and really, as I have discussed, the Littus hernia, which can also become incarcerated and can lead to obstruction. So inflammation, diverticular inflammation may be secondary to the gastric mucosa or pancreatic mucosa, which can cause the pain and other features. So it can be misdiagnosed as appendicitis. So whenever we do laparotomy and we find the appendix as normal, so we have to search the bowel proximally for any Meckel's diverticulum is present or at the time of the operation. So, other mechanisms of stasis include sometimes there is diverticulum kinking and narrow, and enterolith and foreign bodies can also be seen in this Meckel's diverticulum, and sometimes parasites like tinea and can also be present in this Meckel's diverticulum and causing the obstruction. So, obstructive pattern from adhesions or ileus may be the presenting feature. So the preoperative correct diagnosis is uncommon, and occasional CT will show a midline mass with normal appendix. So inflammatory complications are also treated with resection anastomosis. In rare occasions, we do extravasation in the form of stoma. So very rarely or rarely neoplasia can happen in Meckel's diverticulum. Among these neoplasia, it can be benign or malignant tumors. So benign tumors include leiomyomas, lipomas, angiomas, neurofibromas, and malignant tumors include leiomyosarcomas, carcinoids, adenocarcinoma, adenomas, and gastrointestinal stromal tumors and others. So overall, carcinoid is the most common tumor, and the overall carcinoid is the occurs per mucosa, means surface area. It's the most common malignancy. So treatment of Meckel's diverticulum, in elective cases we can do laparoscopic or lap assisted Meckel's diverticulum resection, or open can also be done. The treatment includes a simple resection of the diverticulum and transverse closure at the base, or short segment of the involved means ileum containing the diverticulum, and anastomosis also can be done. Preferably the latter approach is preferred, and patients with bleeding or inflammatory symptoms, we usually the resection of the adjacent ileal segment is the safer option. So coming to the complications include short-term complications and long-term complications. Short-term complications, as we all know, there can be infection of the wound, especially those which are operated in emergency, having the features of bowel gangrene, or there can be an anastomotic leak which can lead to re-exploration and there can be prolonged ileus due to contamination or due to gangrenous bowel changes, and there can be again chances of developing bowel obstruction postoperatively, occasionally requiring re-exploration. So long-term complications include adhesive obstructions and problems secondary to the remnant dysplastic tissue heterotopic mucosa, or when HPR reveals any malignancy or due to inadequate excision requiring us for re-intervene. So feed initiation after surgery. So in the elective cases, whenever we do elective cases, the bowel is healthy. Usually we restart feeds by post-op day 4. So if otherwise the child's clinical condition is not stable, or the child is having prolonged ileus, the clinical course can be, that means the feeding initiation can be tapered according to the clinical status of the child. In emergency cases, there is no fixed protocol. So it depends on case-to-case basis, and depending on the improvement of the clinical status and the bowel movement and decrease in nasogastric aspirates and passing of stools, we initiate the feeds. Coming to the follow-up, usually when we discharge the patient, we usually ask the patient to review with HPR report after 1 week. So if the HPR report is normal and the Meckel's diverticulum margins are free of the gastric mucosa or dysplastic tissue, we ask the child to review again after 3 months. If the child is doing well and no other problems, we ask the child to review if any problem comes. Otherwise, we don't review. And if the report is abnormal, it's like benign tumor or gastric or pancreatic mucosa is present, we monitor the child closely and intervene if required. In case of malignancy detected in HPR, then treatment according to the malignancy. Then coming to the surgical team's experience in handling the case, so all kinds of presentation of Meckel's diverticulum usually come to our department, ranging from persistent vital intestinal duct bleeding, obstruction, etc., treated in our department. And in the last 6 months, we have done about 19 cases of Meckel's diverticulum related problems in our department. Thank you.